Let's talk about two cases that involve the liver. The first is a 53-year-old man with cirrhosis of the liver. Very important that he has cirrhosis. He develops malaise, vague right upper quadrant abdominal discomfort, and a 20-pound weight loss. Physical examination shows a palpable mass that seems to arise from the left lobe of the liver. And most importantly, the alpha-fetoprotein is significantly elevated. Another patient, who also is 53, develops vague right upper quadrant pain and a 20-pound weight loss. Physical examination shows a palpable liver with nodularity. Of importance is 2 years ago, he had a right hemicolectomy for cancer of the ascending colon. His CEA level, carcinoembryonic antigen level, had been normal right after his hemicolectomy, but now is 10 times normal. Two patients, liver masses. The big difference is one has alpha-fetoprotein, which is elevated. The second has had a prior colon resection for cancer, and now his CEA level is elevated. The first one, with the alpha-fetoprotein elevation and cirrhosis, clearly is a hepatocellular carcinoma, sometimes called a hepatoma. It is seen in cirrhotic patients. They have vague right upper quadrant discomfort and certainly constitutional symptomatology such as weight loss. The diagnosis, the tumor marker that is utilized is alpha-fetoprotein. And of course you would get a CAT scan with contrast to outline specifically what processes are going on in the liver, which would be a hepatocellular carcinoma. The treatment, difficult. Surgical resection, if possible, technically. The second case, with a patient who had also a liver mass, an elevated CEA, and a history of a colon resection for cancer. This is metastatic liver cancer, certainly more common than a hepatoma. The diagnosis, a CT scan during follow-up of the primary tumor, CEA level, which again is a tumor marker for metastatic colon cancer, and also a high suspicion. With a history of colon cancer, common things happen commonly. The treatment, even though you may have liver metastases, if the metastases are reasonably confined to one lobe, not terribly large and slow growing, you actually resect them, and the prognosis is reasonable. If they are multiple lobes or fast growing or too large, radioablation is another way you could deal with them. Let's talk about a 24-year-old woman who develops moderate generalized abdominal pain of sudden onset, and then she becomes syncopal, which means she faints. She gets to the emergency room. She's pale, tachycardic, hypotensive. She is clearly in a hypovolemic shock. Her abdomen is mildly distended and tender, and her hemoglobin is 7. No history of trauma. And she says, well, I don't think I'm pregnant because I take the birth control pills since I was 14 years old, and I never missed taking them ever. In this situation, you have a patient clearly that is bleeding, and she gives you a history that makes you think about certain things. What you think about is a hepatic adenoma that has ruptured, and these can occur as a complication of oral contraceptive agents. And they have a tendency to rupture and bleed massively. And I don't mean bleed a little bit, I mean massively. Now in this patient, the question is whether you actually would get a CAT scan on her, because if she was hemodynamically unstable, you never take an unstable patient to the CAT scan. If she was stable, you would do a CAT scan. In this situation, you certainly would do a FAST scan, FAST, F-A-S-T, as you learned in your trauma lecture, focused abdominal sonogram for trauma. Or you might even do a peritoneal lavage in this patient. Irrespective of this patient requires emergency surgery to save their life. And in this situation, you would resect the ruptured adenoma, and this patient would never go on birth control pills ever again. Continuing on in the liver, we have a 44-year-old woman who is recovering from an episode of acute ascending cholangitis secondary to choledocholithiasis. She develops fever and leukocytosis and some tenderness in the right upper quadrant. And a sonogram, an ultrasound, shows a liver abscess. Not surprising. The patient has Charcot's triad: fever, jaundice, and pain. And that is acute ascending cholangitis. And the danger with acute ascending cholangitis is development of a liver abscess. Now, this is clearly what we call a pyogenic or pus-filled liver abscess, and it is a complication of, specifically, ascending cholangitis. And the reason they call it ascending cholangitis instead of descending cholangitis is because it heads upwards, north, to the liver and forms an abscess. And these patients can be exceedingly ill. Now, their presentation, this patient had choledocholithiasis. So usually the classic triad, Charcot's triad, is fever, jaundice, and pain. Will they have leukocytosis? Absolutely. Will they have a tender liver? Absolutely. The diagnosis, they will not make you choose. You could either get an ultrasound or a CAT scan, but certainly, how would you treat this patient? By percutaneous drainage or open drainage? Obviously, you would always try percutaneous first, but if you don't drain a liver abscess, this patient could die. Please follow carefully on this next vignette, because this is a little bit different. 29-year-old migrant worker from Mexico develops fever, leukocytosis, tenderness over the liver, has jaundice, elevated alkaline phosphatase, and an ultrasound of the right upper quadrant shows a normal biliary tree, no stones, but an abscess in the liver. So you've got now a second patient who has an abscess of the liver, but this patient has no stones and is a 29-year-old migrant worker from Mexico. In this situation, one would consider an amoebic abscess of the liver. Why? Because, in large part, of the presentation. He's a male immigrant from Mexico. As you can see, it's similar to the pyogenic abscess. I mean, granted, there's no stones, but it's similar. Serology is the definitive test. Takes 3 weeks. Well, you can't wait for 3 weeks before you treat this patient. So the question is, why don't you just drain this patient like you did the other patient? Because drainage causes complications of spillage of the amoeba. And so therefore, in this situation, you can treat this amoebic abscess, even though you don't have a definitive diagnosis, with metronidazole. Recognize something. You do not have a definitive diagnosis. You have a presumed diagnosis, but not a definitive. Many times, in an amoebic abscess of the liver, treatment with metronidazole works. But now the most important thing. Let's say you're treating with metronidazole, and day after day this patient isn't getting better, and let's say this patient's getting worse. Higher fevers, getting sicker. You do not continue the metronidazole. You take that patient to surgery because, above all, you must be safe. You must be safe. But in this situation, you would initially start with metronidazole, and you will be surprised at how many of these will actually be cured.